Good morning, everyone. It's such a privilege to be able to join this this special conference. Unprecedented, now that it's a combination of all three groups together. Okay, good. It's been a real privilege being able to care for the patients with these different metabolic diseases over the past over 4 decades now. So, I'm glad today to be able to have the opportunity to speak about the organic acid disorders and to share some of my thoughts and ideas that has developed over the years. So these are the various entities that I've been involved with as a consultant, etc. And I wanted to begin to tell you a little story. Jennifer was the first patient with methylmalonic acidemia that I had cared for, and this was way back in the dark ages where there was no newborn screening, and Jennifer presented as a baby in the first 3 weeks of life, but we were able to use gas chromatography to be able to identify that there was a marked elevation of methylmalonic acid in urine. And we subsequently went on to get David Rosenblatt's help and establish that she had the most severe form of the methylmalonyl-CoA mutase deficiency. We began therapy, which of course was a reduced protein diet. We also paid attention to acidosis. There was a need to give bicarbonate to help correct that over time. And I was glad to call Mother every week to talk with her. This was at a time when we really didn't have dietitians in every unit, and so much of the work the physicians were doing themselves. So I was helping to change the protein intake, etc. Based on the levels that we would measure in amino acids, etc. By about a year of age, she was just doing wonderfully, and I actually was a little surprised about how dark the medical literature was on the severe disorders. She was actually a little precocious when it came to language development. But then, unfortunately, the reality set in when she was about 20 months old, where she developed an infection, and overnight, unfortunately, Mother wasn't able to act as quickly as she usually did, and she was finally brought in at around noontime to the pediatrician's office, and she was found to be almost comatose at that time, and her level of bicarbonate in blood was about 2, and she had severe acidemia. She was able to get over that with massive fluid administration. She was getting almost four times maintenance with massive urinary losses as well. But then, unfortunately, about 3 days later, she began to become very irritable, and she was couldn't be consoled, and she started to develop increased tone in her legs, and we asked the neurologist to come and see her, and eventually they did an MRI and said that there's bilateral lesions in the basal ganglia, and it looks like they've undergone destruction. So this is a picture of Jennifer a few years after that episode, but unfortunately it left her not able to to walk again or to eat by mouth and or to speak, and then eventually she died of acute hemorrhagic pancreatitis when she presented at the emergency room and couldn't be resuscitated. So this is, in my estimation, probably the worst, the worst that can happen in terms of problems with MMA, and we eventually published this paper some years later because we didn't know anything at that time about strokes, and coined that title, and subsequently, of course, we realized that this is not something that's so rare. This is a slide from colleagues in Europe about the outcome of classical organic acidemias, namely methylmalonic acidemia, propionic, and isovaleric acidemia, and showing how the severe forms are associated with a poor outcome and survival. So this was a pretty serious issue, for all of us in medicine, caring for patients with MMA and PA, and it was. We realized very soon, how difficult this disease was. Not too long after this acute episode, Professor James Leonard came to visit with us. He was, at that time, one of the world's experts in metabolic diseases, and we were doing visits in the baby ward, and there was a patient who had just with methylmalonic acidemia who had just recovered from having a severe episode, and was still breathing fast, probably because of increased amounts of methylmalonic acid and or hydrogen ion that were present in the brain, causing what looked like a primary metabolic alkalosis. And James turned to me and said, Jerry, this is not a treatable disease, meaning MMA. And I don't think I really answered him, but I kept that in the back of my mind for a number of years. And I think Professor Leonard was wrong. I think we're at a stage right now where things are looking better, and I think things are going to change over the next 5 years, and there is going to be a better outcome for these patients. This talk is divided into 3 parts. The one is to review, especially for those individuals who are maybe new to the societies, what are the list of organic acid disorders first, then to go through some points that I've appreciated over the years, and then lastly to talk about the new genomic treatments that are on the horizon. The last enzyme deficiency on this list, the 3-methylcrotonil-CoA carboxylase deficiency, is actually the most common of the organic acid disorders based on newborn screening results. However, it's only a very small group of individuals that actually become ill as a consequence of this. But the 2 most important serious disorders in terms of the sheer numbers is propionic acidemia and methylmalonic acidemia. And so much of the focus will be on that now. And here's a typical story of a patient, male presenting to the emergency room, is breathing very fast, and is sleepy and on the verge of being comatose, with very low bicarbonate levels in blood, strongly positive ketones, acidemia, and a high plasma ammonia level, and then a newborn screen that shows increased levels of the C3 acylcarnitine in blood, and this is methylmalonic acidemia. It's associated with other metabolite abnormalities, and the enzyme assay can be performed and will show the reduction in activity. Also, want to point out that with methylmalonic acidemia, some newborns in the first 3 days of life can actually be so sick that they require hemodialysis for survival. So that the disorder is not unlike a urea cycle disorder, and sometimes the dialysis doesn't even work. This is a recessive disorder, as everyone knows, and methylmalonic acidemia is also now a subject for liver transplantation. It's been going on for some time since we started it in the U.S. in 1997, and it has had some very significant effects on reducing the amount of acute metabolic abnormalities. Propionic acidemia has similar characteristics to methylmalonic acidemia, although there are some differences in both disorders, and this is also a target for liver transplantation. And lastly, isovaleric acidemia in the early presentation is also a very serious disease, but even more rare. Maple syrup urine disease is also a organic acid disorder, in addition to being a disorder involving the branch chain amino acids. So, but there's a big difference between maple syrup urine disease and MMA and PA in terms of the efficacy. Liver transplantation, virtually can cure maple syrup urine disease, which of course is not the case for those other two disorders. Another abnormality that can be considered to be is the biotinidase deficiency, and this, of course, is a disorder that none of us want to miss because it can be treated very simply and prevent complications by administering biotin. But another example of an organic acid disorder. And lastly, glutaric aciduria type 1, has characteristics of these kind of disorders as well, and unfortunately, acute damage to the brain is also a part of this disease as well. And here is a patient demonstrating the severe dystonia, and there's significant damage to the brain, and also some that are prenatal in origin that has to do with hydraulic abnormalities. So there's a number of items I'd like to share with you today that I have appreciated over time, and I would say that for many patients with methylmalonic and MMA and PA, emesis and anorexia are major features and maybe the most serious problem that exists on a daily basis. Back in the early 80s, we had recognized that patients with severe MMA and PA almost always had problems with feeding and with intermittent vomiting, even if they weren't ketotic or appeared to be acutely ill, and this would go on day after day. And the etiology of this is really not clear. I think it's possible that there's some sensors that exist that allow for the brain to realize that the food that the patient is consuming may actually not be good for them, and maybe somehow initiate a lack of desire to feed. Unfortunately, it took us quite a while to realize that our nurse practitioner was right all along, that it really is not inappropriate to provide a G-tube for many of these patients, because that will allow them to grow properly, and otherwise one might it might take months and months before you realize that, and during that time period the patients are not growing well. So one other issue that's come up is does a strict protein restriction do more harm than good? And also linked with that is are there complications that we can contribute to the overzealous administration of the amino acid containing medical foods? And I know this is something that the NIH group has addressed recently. This also is an area that still requires more clarification. I think we don't really understand this, but most of us try to use a mixture of biologic protein restriction as well as giving the amino acid mixtures. So another issue is, why is the liver so important in acute metabolic decompensation? Because this is a phenomenon that almost all of the time disappears after a patient is given liver transplant, and it could be something as simple as no longer the production of ketone bodies. It also could be related to lactic acid accumulation in the liver, but it's not entirely clear. But metabolic specialists have appreciated this. Why should we dwell on this? Well, maybe there is some type of switch that goes off in the liver, and if we could figure that out, maybe we could use a pharmacologic approach to try to prevent that from happening, or to reduce the amount of problems. The cytopenias, this is another interesting problem. We all learned many years ago that in patients that have these fatty acid disorders of organic acid metabolism, that acutely they can develop a drop in their blood counts, the red blood cells, white blood cells, platelets, and it may reach a peak maybe 5 to 10 days after the acute episode. But there's also a new phenomenon that we've kind of recognized since the late 80s, 90s, of patients with chronic cytopenias, and that may have a different etiology, and that also requires some further studies. One interesting observation is that classic brain edema or pseudotumor cerebri almost never occurs in patients with MMA and PA as it does in patients with MSUD. Yes, there are stroke-like problems that exist, but the kind of lethal brain edema that's so common in MSUD does not seem to be present. Another important issue is during an acute episode, patients can demonstrate a severe loss of free water. As the patient I mentioned earlier on, it's not clear exactly what triggers this phenomenon, It could be something as simple as increased calcium ions in the distal renal tubular cells, but this is something else that requires some attention. One of the things that we had studied, Paige Kaplan and I, to begin with, about 20 years ago, we looked at the apparent de novo production of MMA in brain, and it's usually higher in brain than it is in the non-CNS tissues. We can demonstrate this by simultaneously measuring cerebrospinal fluid, MMA, and also in blood. Following a successful liver transplantation, the levels of MMA as well as methyl citrate do not decrease in brain and spinal fluid, but they do in blood, and this also, it's not published, but this phenomenon also to a lesser degree can be seen in propionic acidemia. Over these decades, we began to realize that there's other problems that exist, such as pancreatitis, the bilateral optic atrophy, skin lesions, and perhaps even more significant immunodeficiencies that are not easily understood. One thing that's always remained unknown is the acute stroke that largely involves the globus pallidus and MMA, and the subacute or chronic stroke involving the caudate and putamen are almost always in the first 5 years of life, although we have had some patients happened later. For example, we had a 13-year-old who showed the classic bilateral striatal problem following a severe H1N1 infection. The cardiomyopathy is not infrequent in propionic acidemia, and it's extremely unpredictable and dangerous. Cardiac abnormalities have been reported in some patients with MMA. So there's similarities between the two diseases, but some differences as well. And understanding these better would only help us try to generate new treatment strategies. So liver transplantation for methylmalonic acidopathy, it can help, but it's not without its risks. We wish there was something different. And so moving into the last part of this, I want to begin to review with you some of the new therapies that are genomic in nature. And Dr. Chuck Vendetti and Paolo Martina teamed together to try to begin a new therapy for MMA, and this was a very important paper that where they showed in the cell reports that you could use messenger RNA as a treatment. They found that that when they systemically delivered a lipid nanoparticle that contained messenger RNA in the middle of it, this would be the messenger RNA that would allow methylmalonic acid protein to be made, that it had a significant effect on the longevity of the mice, and also showed very nice clinical. And this was an important paper that suggested that maybe this kind of therapy could be used for patients. The way this would work is that the patient would be given an injection of this nanoparticle, and it would travel in the blood, and because of some compounds that exist on the outside, it would make its way to the liver primarily, but not exclusively, and it would then be able to get taken up into the cell, and would get into a compartment that is related as a precursor to the lysosomes. While in there, a change in pH would allow the material to be released through the wall and into the cytoplasm, and it would go to the ribosomes. Protein would be made, and that protein would have the right markers on it, and it would then go to the mitochondria and be taken up and function. So this is a new potential therapy for patients with both MMA and PA. The same enzyme that would be defective in methylmalonic acidemia, or one of the two that would be defective in PA, could be replenished with this treatment. How often this therapy needs to be given is not clear, but in the studies that are being performed now, it appears that perhaps every 2 weeks to 3 weeks to 4 weeks might be the schedule. So that has its complications in terms of the need to every month for testing to be done, but it may be the beginning. It may be the beginning of something that's new. I think that both of these diseases are now going to enjoy a new intense work that involves finding genomic therapies that's going to be helpful. It's just beginning, but I really think there's room for hope. There's a phase 1-2 study of the RNA 3705 in MMA due to the MUT deficiency, and this is already started, and there's data that already exists from Europe and also Canada, and my understanding is that at least one site in the U.S. has been identified, and I think recruitment's beginning now for this study. There's a lot of work that needs to be done in this genomic therapeutic area, and it's not just the messenger RNA therapy, but there's also the possibility of doing gene editing, which theoretically probably would be most ideal. This would allow someone to get an injection of a vehicle that would contain the DNA that would be corrected, but all this needs to be studied very carefully, and so that we're clear that there's no side effects related to it. There are concerns that sometimes injecting material into the body that's going to get into DNA could have some long-term effects, and this is something that really needs to be worked out. There's a large amount of ethical issues that exist that need to be cleared up. For example, if we have a disease where there's already a treatment, it would not make sense to expose a patient to that treatment that might have significant consequences later on. On the other hand, if it's a life-threatening problem and a therapy that could be given and only once, it might be reasonable to do that. Dr. Vendetti and his colleagues are going to speak more today about the genomic therapies, and as I said before, I think the future may be bright with this approach. So I'll stop now, and thank you for your attention, and glad to take any questions. Thank you. Yeah.
So, can you? Here's the microphone right now. Okay. So, I'm Kim Chapman from Children's National. Okay, Jerry, you've been doing this for 40 years. Can you talk about the successes of when you walked onto the floor 40 years ago for, say, MMA or CBS deficiency, and how much better it's gotten when you see a patient for the first time with one of those diagnoses or one of those suspected diagnoses if it's a newborn screen?
Yeah, thanks for that question. Well, number one, I think just being prepared makes such a difference. And the fact that there are now in the different units around the continent, in the United States, Canada, etc., where individuals can respond right away, that we're better off. You know, we're better off than we were before. We also have protocols that we didn't have before, which are very important, so that we all can provide the treatment in a uniform way. I'm a great believer of that, because I think you don't learn very much by one person doing one thing in one center. We all need to work together as a team. So I think also the NIH getting involved with this, with the Rare Disease Network, also helps, so that we can. This has been especially true for the urea cycle problems, where we've all been able to sit down together, try to put together the same treatment plans, and then see where there's problems. So organization, I think is important. I think back, when I started in 1978, it was not clear that really some patients with MMA and PA really need alkali therapy every day to be able to produce, to be an acid-base balance. And so we know that if that doesn't work well, then you're at risk. You're at risk for not growing properly. So I think there's a large number of little steps like that. But I think right now we're poised to make the big steps because of the technologies that exist that didn't before.
And I haven't done this as long as you have, because I'm not quite as young as you are. But I would say that the family groups have helped us immensely, because they provide financial support to research. They help support us. They help support our families. Our families are much more educated when they walk into the clinic. I think, and then just things like support for medical foods, ideas of cooking, those kinds of things. It's really much better than it was even 20 years ago.
Oh, it's absolutely wonderful. And when we started off, over 4 decades ago, the medical schools still had this idea that physicians function on their own, which is nonsense. In fact, that's part of the beauty of metabolic diseases as a field, is being able to work so closely with families. I mean, that's really a wonderful thing, because we can't do this by ourselves. And I routinely now will ask the family to try to help us decide what's the best treatment plan because sometimes a individual medicine approach is better than actually doing things by the book. So and we need the families to help guide us with that. So thank you.
Thank you, Dr. Berry, for your excellent talk. Could you comment on progress that's been made over the years with classical homocystinuria? I know you're more focused yourself on treating some of the organic acidemias, but I know you're close to it, and I'm sure have seen the progress. Can you give us some of your perspectives on what's changed and what you see coming in the future?
Well, I just wish that that in MMA and PA, that the same kind of success that's occurring right now with this, I guess, how shall I put it, the extracytoplasmic therapy of using an enzyme, I think is tremendous, and the data from that speaks for itself. So I think this is a great example where you can do something that's novel, but at first glance you might think this wouldn't work at all, but it does, and I think it's going to have a complete change for treatment for homocystinuria. It's really very exciting.
Thank you, and I'd encourage people in the audience to ask questions. If you want to raise your hand after I ask one more, I'll actually bring the mic to you, and you don't have to stand up, which I know can be intimidating. So the other question I'd like to ask relates to newborn screening. Can you just comment in general the current state of newborn screening for all of these disorders, organic acidemias, homocysteinurias, et cetera, and any changes you would expect to see in the future? Thank you.
Yes, that's such an important question. The newborn screening now uses, state-of-the-art mass spectrometry for diagnosis, but this does not always. It doesn't always work. And one of the things that we need to figure out what to do is how to analyze some of these metabolites in an easier way, because most of the newborn screening facilities right now can't do this more how shall I put it, more elaborate testing because of the time it costs and the money that's put into it. But I think we can do it. I think it requires just some little tweaks in technology, and we can get there. I just wish we had a uniform way of doing this in the United States. I think the idea of each state doing their own thing doesn't make a lot of sense. I think it's stupid and it's antiquated. So,
I have a question. I have actually a couple of questions. What advice would you, if a family is struggling in their clinic with communication and feel like they're kind of hitting a wall? We don't all get the luxury of moving clinics, just because for some of us, the closest clinic is still, 5 hours away. What advice do you have for families that are struggling with their current clinic situation and how to remedy it and make it better?
This actually gets to another issue, and I'll be honest with you, I'm a little worried right now about the state of affairs in the metabolic biochemical genetics facilities. I think the emphasis on finances, I think, is hurting the medical system. It's interfering with proper care. And I really, if there was one thing that I would hope that the families could do, would be to somehow make the patients the priority for the hospitals, and not trying to meet their financial needs. I think this is very much linked together. I don't see why we can't do some family visits. Do some home visits for families, or see them on the weekends when it doesn't hurt them with regard to work. I know even in my own institution, there's very little of that done, again, because they want so much oversight, and they want the whole team to be brought in, and then that becomes not financially suitable. But I think we can do something more clever like that and put the patients first.
I think as the executive director, as a patient organization, this is also where patient organizations come in also and help support families too, because clinics need support, patients need support. We all are in this together, which is kind of our theme here. And so I think it's important for the patients to know that we support the clinics too. The clinics know that we're here to support them. It's reciprocal.
Yeah. This really is something that we need the families in the United States to do, and to do it in concert with other facilities, but with your oversights. We need you and other organizations to help provide guidance. But it's like bad things happen when people don't vote, and we end up with a mess. And I think we need to get more families involved, because when you put all the rare diseases together, it's not rare, and they need help.
Yeah. I have one last question. In the classical HCU community, sometimes patients they can sometimes struggle, and coming to clinic happens less and less the older patients get, especially as teenagers and then as adults. And one of the things that I often hear is patients, they don't really know what to do with the clinic visit. They know they're struggling, but they don't want to go in and just be scolded. And so how do you feel patients who are struggling can best prepare themselves for a clinic visit, or new families that have a later diagnosis? How do you feel we can best prepare?
I think all this depends on us, as physicians and the other caregivers. I don't see any benefit from hollering at a patient or belittling them because they didn't do so and so. Many of these diseases are very difficult, to deal with on a day-to-day basis, and the wonderful families have been able to do this. I think we need to make it easier for those individuals, especially the adults. We're really struggling now more than ever in trying to get the proper home for the adults with metabolic disease. In other words, the patient with propionic acidemia who's now 30 years old, and the Children's Hospital may not necessarily want them to be seen there, and the adult hospitals are not prepared, and again because of money related things. But I think what we need is a team of the physician, the dietitians, the social worker, other ancillary individuals, planning when those patients come in, and try to anticipate what their needs are. Because for some of them, it's just the ride to the visit that's a big problem, and I think we could be doing a better job with that as well.
Thank you so much. Does anyone else have questions? We can bring the mic around. Oh.
Yeah, I was surprised. You made a comment about there is a discussion on following the restricted amino acid diet. Can you elaborate on that?
Yeah. Yes. No. So the issue, I'll just say it out for the group. The issue is how does one place a patient with MMA or PA on a diet therapy that's restricted in biological protein, and then at the same time administer to them amino acids that are not toxic. This has been a problem for over 4 decades. The question is, ideally what we like to do is to give a reduced amount of of protein that will allow the levels to still stay in the normal range, but will permit growth. And sometimes it gets almost impossible to do that. We were excited decades ago when the medical foods became available. We could give that and increase levels, but there is some concern about that, mainly related to transport problems, where if you, for example, give a large amount of leucine as a supplement to a patient, that might further cause may further cause levels of the other two amino acids to be further interfered with moving into the cell, and so you're actually causing a nutritional problem. So it's a little complicated. It's probably best done with a blackboard and with some showing exactly what we mean by this. But it's the issue of how can one reduce the toxic amount of compounds as best, but still preserve growth, and then also help maintain a better supply of all the amino acids without causing a secondary problem. And one person just stood up who's done a lot of work in this area.
I was asked to comment and for the amino acids, because we have tried a lot over the years to learn more and understand and change our guidelines and make it more unified across what all the clinics are doing about medical foods and amino acids, and specifically for MMA and PA. And I want to make sure we don't confuse here. There is a variety of family groups from different diagnoses, and that was one of the issues. Classic homocystinuria has different dietary needs, from methylmalonic and propionic acidemia, and then with people with cobalamin disorders that have methylmalonic and homocystinuria. And then doctors and clinics have used sometimes the same dietary approach for many diseases. That was not appropriate. But we have changed our guidelines, and we're trying to do different things for each of the different groups of diseases. So if we use amino acid formulas for MMA, for the cobalamin children, that was not the right approach, and we are not doing that anymore. The homocystinuria has different diets and different amino acid mixtures. So it's a big group of parents here, so this doesn't apply for everyone. But we had medical foods for MMA and PA that had the formulation was so that if we use too much of those medical foods, it was a problem. So we now have changed that, and we have new guidelines that we know the perfect ratio between the natural protein and the medical food protein, and to avoid this effect of the leucine that Dr. Berry explained. So we learned more analyzing everybody's data with our research, and we now have a better balance in the mixtures that we use that avoids this problem. Medical foods are critical for the care of metabolic disease patients. They're very important and very useful. We just learn how to use them the right way to avoid any problems. But it's very different across all the diseases that are here. So classic homocystinuria is very different than MMA and PA and cobalamin disorders. So not the same diet for everyone. And that caused confusions both for family and physicians. So we are learning, and with all your help, we're doing better.
All right, any other questions? Oh. Did you have a question?
How do you decide what conditions are good for the liver transplants?
How do we decide?
How do you decide which conditions work for the liver transplants?
We use the information that comes when a patient undergoes a liver transplant, whether the biochemicals that are elevated return to normal or not. That's one thing, and then how the patients do. So for propionic acidemia and methylmalonic acidemia, we we know that in MMA, the levels of methylmalonic acid when you do a liver transplant can drop by 50%, or maybe even to 1/4 of one quarter of the total, and when you then look at how many times the patients have to come into the hospital because of an acute metabolic decompensation with high ketones, with acid buildup, and we know that those numbers of events are decreasing. That's telling us that there's a better clinical outcome. We find similar things with methyl, with PA. There's also a drop in levels, but at the same time, there are other complications that exist that might still happen even though you've gone through the transplantation. So we have to work with the family carefully, and with our ethics group when we do something like this, so that we make sure that the family understands what complications might still exist, and that there may be complications from the surgery itself, and we have to be careful about that. And each patient needs to be treated individually. Does that help answer your question? This was, I'm sorry, I missed that. This was for classical. Did you? Oh, I see. Yes. Well, that's a little bit of a different issue. Kim, you want to respond? Yep.
Yeah. Hi. Jerry Fockley from Pittsburgh, and we do a lot of metabolic liver transplants, and probably have done more PA and MMA transplants than anyone in the country, but not homocystinuria. And part of the issue is looking at risk-benefit ratio. And I'm going to be really blunt about this. Any procedure that starts with step 1, remove liver, think twice about it. I mean, this is not a lightly considered approach. And so if it's clear that our metabolic therapy, and I'm not the liver transplanter, I'm the metabolic guy, so I'm the one that's trying to keep people away from liver transplant. But when it becomes clear that the standard of care for our diseases is not working very well, that we're getting lots of hospitalizations, lots of complications, especially the devastating neurologic complications that Dr. Berry talked about in his talk, then you start thinking about more drastic procedures, i.e. remove liver. But you really have to get to that line beforehand to want to get to that. Now, Chris, I don't know you. I don't know your clinical history, and I can say that we treat a lot of homocystinuria patients, and for the most part we're able to do really well with managing their disease medically. Is there a time when we would ever consider treating somebody with homocystinuria with a liver transplant? I think the answer is never say never, but it would really have to be an extreme case where it's just clear that there was no way to manage things medically. So it's you know, when you see something that you think ought to work for you and it's not available, that's very frustrating. But I think also Dr. Berry has pointed out that for homocystinuria, we're actually maybe much closer to that magic bullet medicine than we are with PA and MMA and some of the other organic acidurias. And so I would encourage you to look into that rather than trying to push for something that's where there are significant risks to the procedure as well as consequences of the long-term immunosuppressive follow-up. So
yeah, I just realized that you don't have to remove the whole liver.
In our setting, the surgeons who have tried to do partial liver replacement have had no success with that procedure. And they're magicians. I mean, you know, and when I moved to Pittsburgh, people said, watch out, those guys will transplant anything. And now I'm there and I say, oh, wow, I can transplant anything. So if I think it'll work, I'm really, you know, so there are limitations technically that for that. And the other thing that Dr. Chapman is whispering in my ear behind me, I'm her ventriloquist dummy actually, is that the risk for clotting in homocystinuria is really significant compared to like PA and MMA. And I'll even tell you that in PA and MMA, the risk for clotting is higher than it is for like the urea cycle defects. And so each one of those risks adds up to whether or not it's possible to treat with a liver transplant, or it makes sense in this era where I think Dr. Berry's right. 5 years from now, we are going to be in a really, really different place for most of the diseases that you all are dealing with here in this room. And so I think my plea to you would be to look into what's going on in terms of clinical trials because if anything's made it to clinical trials, there's really a lot of evidence behind it that says this is likely to work. It's not for sure because it's still research, but it's the clinical research. But there's a good chance that it's going to work because of all of the work that's been done up to it. So I, given the chance, would rather participate in a clinical trial than have a liver transplant. And I do I work with my liver transplant team and do them frequently. So.
Hi, Dr. Berry. I had a question as a number of our families have their children getting older into adulthood in terms of helping with transition to adult care from the clinics.
Yeah, this is something we're really, really interested in, and we've been I'll just be honest with you, we've been struggling in Boston with this, trying to get the Brigham and Women's Hospital or Mass General or Beth Israel to work with us. You know, we would love to do this. It involves finance, and you know, we would start tomorrow to set up a clinic in any of those hospitals, but it's been a struggle. It's been a struggle, and I think we can get it done, but. Many of my predecessors have tried for the past several decades without success. But now that the patients are growing more and more, there's more adults because of the better care, we really need to find the proper home for them. It's, you know, at Boston Children's Hospital, the chief of the hospital has always said, you know, all the patients are welcome to come back. But the reality is, if someone has chest pain and adult-like problems, it's probably not the best place for them to be. And they really ought to be in the adult hospital with us behaving as consultants while they're under general medicine. But it's easier said than done, unfortunately.
And I, unfortunately, am the internist in the room. So I'm a metabolist and a geneticist and an internist and a pediatrician. But transition and a transition is one of the major issues we're seeing in metabolic disease. And part of this is because internists think about genetic disease as being a pediatric problem, right? And so having people transition, especially for the other services. So Jerry and Irini and I'm looking to see if I can see Mark should be in here someplace. We're all boarded so that we can do prenatal to grave. But most of us are set within a pediatric setting. And so you can potentially always see your metabolist, but the problem is who's going to be your nephrologist? Who's going to be your cardiologist? Who's going to be your internist? Who's going to be so on and so forth? And trust me, when you're 6'4", you don't fit in a pediatric bed and you're 26 years old, right? And the hospitalists in the pediatric hospital are licensed to 26. So this is a really big issue in terms of transition. And we in the field are really aware of it. Like, we know this is a problem. And the newborn screening has changed it because we've got all these patients that are now living to adulthood. Let's talk about how much progress we've made over time, because before that, internists saying, oh, that's a pediatric problem, they can stay at the pediatric hospital, was probably okay. Now it's not. And so some of the things you all can do to help us is if you find someone that's particularly interested in your disorder, whatever the disorder is, make sure your metabolist knows that that person's interested. Talk to your internal medicine providers. Find an internal medicine provider who's interested. I just spent an hour yesterday sitting with someone whose job is to find nephrologists who can take care of cystinosis. Now, cystinosis, everybody just nod your head. But these folks have renal failure, and they have renal failure in young adulthood. A lot of them do. And they're like, we can't find adult nephrologists. And I'm like, well, you're going to have to find a fellow in an academic center who wants to make their career that way. So think of it that way in metabolic. That's how we get providers in the transitional area, is you find that med student that you can make really interested as they're following their metabolist. You find that provider that is sort of junior, that fellow that's junior, that becomes really interested, because those are the people that I think we're going to have to recruit to help us take care of folks as we get older. Because unfortunately, there's 140 metabolists that see patients in the United States. That's it. That number hasn't gone up. That number has gone a little down. There's not enough people that take the metabolism boards to replace the people who retire. And so anything you can do to help us find adult providers is really essential. And that's kind of a downer, but...
No, I was going to just follow up a little bit on agreeing with Kim's note that families have been very supportive for this. Like, family organizations have provided small funds for young investigators and young students, even in our lab or in many other academic settings, where someone can start up a little project and a funding and a research trial, and they have been enormously helpful for that. And we thank you all for your support through the years. Yeah. So.